So what I would like to do, so I know there's a lot of questions, but I do want to have some time to go on to the next portion of our workshop for today, and that is a research project that Elizabeth Nielsen and I have been involved in. We have started this, I think, about a year ago, and this is the title, The Role of Psychedelic Therapists in Psilocybin-Assisted Therapy. This is Elizabeth, who's the primary investigator. Her affiliations are NIA, the NYU College of Nursing. And these are the aims of the study: to highlight the role of psychedelic therapy in producing change, to identify the key processes known to occur in psychodynamic and other forms of psychedelic therapy, and how psychedelic therapy is thought to work. So this is our interview guide. We have the opening phase. We have a couple of aims. How did you come to work on this? How do you think it works? How do you build a rapport? Transference and countertransference, self-disclosure, boundaries, therapist expectations and values, touch, difficult experiences. And we've analyzed 4 of the 8 projects, but before we go into talking about that, I want to introduce Elizabeth and invite her to tell you a little bit more about this study.
Do you want me to put that on? I could just talk really, I can try to just talk loud. That good? Okay.
Yeah.
Do I look silly? Can you hear me? Both? Both? Yes?
Perfect.
Okay, good. Okay, great. Thank you everybody for coming. It's so wonderful to see so many people interested in psychedelic therapy. It's awesome. And I was downstairs and saw the other room full of people too. I'm like, wow, this is great. It feels like there's so few of us because we see each other and the same, 5 or 6 people doing this for several years, and then we get here and it's like there's a whole room full. It's really, really wonderful. So I'll give you sort of the backstory, the things that you hear about research projects. Why I like hearing about them from researchers at conferences is because you kind of get to hear the story behind the research and not just the published results that you would see in a journal. About a year and a half to 2 years ago, I was beginning a postdoctoral fellowship with a focus on developing my own program of qualitative research and also training to be a psychedelic therapist at NYU with Jeff Guss and Steve Ross and the rest of the team there. And I wanted to do a project that would in some way document and investigate the positions and the thoughts of the existing psychedelic therapists, the psilocybin therapists at that time, and still to this day. It's a very small group of highly specialized, highly passionate individuals that are doing this work in the research studies. There are a couple of reasons that I was interested in doing this. One is because, as I said, you do have this sort of highly unique group of individuals that are really in some ways making this up as they go along. I mean, there is no guide, there is no established training program, there's no established set of experiences or credentials or number of supervised hours that one needs to be able to do this. And this is the sort of the group of people that are going to be setting the standards, I think, for the next generations of psychedelic therapists, hopefully, that are going to come many, many, many more after them. So I thought it'd be an interesting group to talk to. There didn't seem to be a whole lot of agreement or consensus necessarily about even how psychedelic therapy works, what the elements should be. I mean, we had this psycholytic model, we had the idea of preparatory dosing and integration, but beyond that, as you were just saying, depending on the psychedelic researcher's approach, they could be seeing different themes, more relational themes, more spiritual themes. So I thought it'd be a really interesting group of people to talk to, and needing to sort of start one of my own projects, that was what I chose. It was a bit of a battle to get something that we could agree on, that we would agree would be a safe and helpful study to do. And again, we are talking about a very small group of highly motivated but also very busy individuals. So getting people to take the time to sit down and talk has taken a little bit of persistence. But usually if somebody's interested, within the next 3 or 4 months, I can get an appointment. So we decided to look at a couple things, and Jeff just showed you the aims of the study. You might have noticed one was grayed out, and I'll explain that. One of my initial intentions was to look at the actual therapy manuals that are written and see how therapists are using them. When I started talking to people, I realized that actually most of the people that I'm talking to were the ones writing the manuals. So the distinction between writing and using a manual or revising it got a little blurry. And I figured that might be a better aim to include in a later study where I'm maybe talking to therapist trainees and how they conceive of the manual and implement it, as opposed to this particular group. So we've focused less on that. Some of the studies also didn't even really have a formal manual, as we had initially thought that they would. So that's kind of how the study came into being. I can tell you that so far we have we received our IRB approval from National Development and Research Institutes. We had several collaborators coming together to help design the study, make it work. Again, myself, Jeff, Steve Ross, a qualitative researcher, Honoria Guarino from National Development and Research Institutes worked on it. And we also had some collaboration from Roland Griffiths of Johns Hopkins and Cody Swift of Riverstyx on the design. So it was a collaborative group effort to get this thing off the ground and move forward in a way that could work. I'll tell you a little bit about the structure for analysis. So far we've completed 6 interviews. We are right now working on what I call an interim analysis, where we take those first 4 interviews. We're looking for 2 kinds of themes. We're looking for themes that were predefined in the literature. So things like how therapists deal with transference, how therapists deal with setting relational boundaries in psychedelic therapy, how therapists approach things like the theme of touch, how they're working with touch, how they are generating rapport, building alliance, how they work through alliance ruptures. Those are all things that are sort of reasonably well outlined in the psychotherapy literature. And we want to ask therapists how they're approaching those topics and how they're dealing with those things in psychedelic therapy. We also asked about difficult experiences, how they see the role of difficult experiences. So we've got 7 of those existing themes that are already in the literature. We can kind of go back and say, this is how psychedelic therapy treats these things that we already know are issues in therapy. The other part of our analysis is to look for what we call emergent themes. So these are things that we haven't already thought of. And qualitative research is all about asking open-ended questions and then seeing what your participants provide and what do they come up with that we haven't thought of already, because part of our job as qualitative researchers is to know we don't know everything. So instead of in a clinical trial, you've got preset questions. You're saying, this is my hypothesis. Do I accept it or do I reject it based on my data? But it's a closed question. It's yes, no. With qualitative research, we're looking more at open-ended questions and saying, what comes out of this? So we do an interim analysis. We go through our first 4 interviews, and we're going to hear some about the emergent themes that we found in those first 4 interviews that we've analyzed. And we'll go back. We'll probably be collecting another 2 to 4 interviews, so we'll have a total of maybe 10. And we will look at that next set of interviews and see, is there more coming out of this? What else are we finding? Is what we're finding in the later batch consistent with the first batch? Are we finding a totally different set of things? And that'll help us determine if we've reached what's called saturation, which means we're pretty certain that if we interview another 10 people, we're not going to find another 10 different answers to those questions. So I think I'll let you go back to talking here and talk about some of the emergent themes. Before I step off, the questions about sort of the study design ideas, how this came to be? Is there anything? I'll be here afterward too to take questions. But yeah, the interviews last They last about 60 to 75 minutes. Yeah. I ask people to schedule an hour and a half phone call. We do our informed consent first and answer questions, and there's a little survey that they'll fill out with their, what research projects they've worked on, that kind of data, and then the interview is usually an hour to 75 minutes. Yeah, yeah.
Are there differences between the different patient populations that are being worked with in the active trials?
Yeah, so this study is just psilocybin therapists, although there are some psilocybin therapists that have also worked with MDMA, so there's a little bit of overlap, but we're really just asking about the psilocybin work. And we are covering therapists who have worked with a variety of diagnoses in clinical trials. So it's including people that have worked on cancer, anxiety trials, addiction treatment trials. It's a variety. Yeah, it could be any of those. It's not limited to one diagnosis. Right. Good question. Okay, yeah?
So in the psychotherapy literature, we often see that therapists think that they're doing something, and then the therapy observes, we see something else.
Mm-hmm.
Do you have a plan to kind of triangulate with observations of video footage? Is that part of what you want to do?
No. The way that this study is designed, we're really looking at how do therapists conceptualize psychedelic therapy. That may not be how the participant would say it works, and there are other studies that look at how the participant says it works, and there are other projects that look at transcripts of sessions. Like I'm working on a paper right now that's looking at transcripts of debriefing sessions to see and content analysis and see what is actually said and how does that relate to outcomes. But this is specifically looking at how do the therapists conceptualize this. It doesn't necessarily mean that's like the truth. I don't know if there is one truth about it or about anything, but this is like the therapist's perspective. What do they say? How do they come at it? Right. We're giving that voice. And another step in the process will be once we get all those interviews together, we'll write a summary. I'll write a summary of preliminary findings and send that back out to therapists to sort of read over and take a look at and say, oh, yeah, that's interesting. I want to make another comment. I think you missed something. So we'll get that collaboration as well. All right, I'm going to turn this back over, and I'll come back on later for questions. Thanks.
So we have about 35 minutes left. And in the interest of not just talking and talking and talking endlessly, I am going to go through these slides and invite you to read them. I'm going to read one or two phrases from each one. And I've highlighted some, but I think that there's way too many for me to read out loud to you. But I want to emphasize these are the themes: rapport, therapist preparation, following intuition, the therapist motivation and frame of mind and state of mind, the participant's arc of transformation and transcendence. So, rapport between the participant and the therapist, a very deep and genuine rapport, being present with the person, open, genuine, respectful. I'm completely there for you. Forming a relationship. Not only are they safe physically, but they're safe emotionally. Really listening, deep listening. We're not trying to change them. We're not trying to direct them in any way. And the relationship between the therapists, not with the participant, but between the therapists. We need to be very aware of where we are emotionally in the presence of each other. Good rapport, good communication between the therapists. Because if there's conflict or tension, the patient's senses are amplified and they'll pick it up. Okay, the next category, therapist preparation. Being well trained, being centered and strong and non-anxious. Anxiety is contagious. If you're afraid of sex or death or God, you can't help people in those areas. I try to have good relationships. I meditate. I know one therapist who couldn't resist sticking his face in front of the camera and showing off his acumen. The outcome was not good. Therapist preparation. This is why I became a doctor. It's a fulfillment of a dream. I feel honored. You've got to be careful not to be a disturbing presence to a patient in the session. That we give attention to the original pioneers and respect the shamanic model. Solid clinical training, a solid history of psychodynamic training, your own personal therapeutic history is important in becoming a psychedelic therapist. Following intuition. The words I say are so intuitive. To unconditionally trust your own mind. There are times when the body is like a newborn child. The body on the couch is the wisest you could ever meet. You could find yourself crying with the person. To enter into the mind space, not to judge or to try to find a solution for them. I'm not as actively involved in talking. Oh, this is the effects of talking versus intuitive silence. I'm not as actively involved in talking. I'm more reflective. I'm in a more meditative state. There's so little dialogue, encouraging them to be the person that has the experience. Even when it's really tough, that woman who thought she was going crazy, in another type of setting, she might have gotten up and talked to somebody and gotten reassurance. She might have been able to be calmed down, but she wouldn't have gotten to the point where she let herself go into the experience and had that transformative moment. Again, talking versus intuitive silence. There's a lot going on, even though we're not speaking. A skill of understanding where you are where they are at a given time, even though you don't really know. Don't interrupt them or talk too much, because there's nothing we can say. Very few words are spoken. So much went on between us. We sat there, the three of us, holding each other. Now, this is the therapist observation of the participants' intentions and motivation. So remember, I was talking before about, when I showed those telescopes, what the therapist's belief systems are. This is an example of what one of the therapist's belief system is. And I think it's a common one in Western therapists. The drug gives an opportunity. How the person responds to that opportunity depends on their motivation, the trust, and the psychological conflicts they're working with. In the course of the sessions, people seem to get more clarity about what it is they really want and how they're going to achieve it, getting clearer about their goals and the kinds of changes they want to make. Now, this is a distinctly non-shamanic type of language. People wouldn't speak this way if they lived in a shamanic culture and they were going to a shaman for help with a problem. This is a very Western model of psychological mindedness. And this is a therapist saying what he or she believes they're doing is getting clearer about their goals and the kinds of changes they want to make. And this is a therapist that was working in the alcohol program. And in the cancer anxiety study, we didn't really give people any kind of guidance on what we thought they ought to be doing. But in the alcohol study, we did give them the guidance that we thought they should be thinking about their relationship to alcohol. And it was a relationship that was important to them, and that's what they were in the study. So it's I think, a good example of how a study for a different kind of condition can have very different purpose to it. The therapist's observation of the participant's intention. The therapist brings into focus what their intentions are, how they can move forward. The intentions for being in the study crystallized and clear. Why are you doing this? My intention is to experience the dark side. I went, oh shit, it's going to be a long night. So these are the therapists, in these academic settings saying the intentions are really important to clarify and to expect the person to be making some kind of a progress along the lines of those intentions. The therapist's state of mind and actions. Openness. I don't have any agenda to prove, either atheistically or theistically. Whatever comes up, we'll meet it. You can laugh, you can scream, you can cry, you can be silent. There's no proper behavior, just be real. Therapeutic actions taken. I'll be with you. If you need to vomit, I'll be with you. I'll touch you. Touch is very appropriate. I go and take the person's hand. There are times when people are sobbing so intensely, intuitively, a hug or placing hands on the shoulders, very important. So these are actions that the therapist described taking. These are metaphors that the therapist used. You're the astronaut, I'm your ground control. This touch is grounding in the electrical circuit, like there's an energy from my arm going into your arm, and your arm going into my arm. You're not dangling from a cliff, hanging on desperately. It's simply being in the world together. Everything is well choreographed, it's all amplified. The therapist's mental set. This is what the therapist is supposed to be, the mindset that they're supposed to be in. To foster security, courage, openness, curiosity, and adventure. So the goal of the therapist is to foster all these things, according to this therapist report. To be present with another person, and to be aware of your own reaction to what's happening in the room. If they're having a difficult or anxiety-provoking moment, encourage them to stay with it. Liberating experience of transcendent, of love and acceptance. So again, here's the theme of encouraging tolerance of intense affective states rather than reassurance and trying to ameliorate or improve them to a lower affective level. So now these are participants' arc of transformation, but I have in gray, it's the therapist narrative of the participant's arc. So this is what the therapists think is happening for the participant. It allows individuals to step out of their lives and view themselves from a new perspective. They come out of it with far more depth sense of who they are. They gain momentum to move forward and integrate their new insights. They're the same but different. Acceptance of natural cycles of birth and death. So these are therapist ideas of what they think is happening. And I guess what they think should happen in psychedelic therapy. There's an arc of again, the participant's arc of transformation. Even if you don't have transcendental experiences on a psychodynamic level, made very significant strides in resolving relationships. It's ideal to have both the mystical and the psychodynamic. Sometimes it goes from mystical to psychodynamic other way. Then one therapist said, I have a little tendency to underestimate how important experiences may be that do not include a complete death and rebirth. What? Yes. Well, there also is an idea within the research world that the more complete the mystical experience, the greater the transformation. So it becomes a kind of seeking after a completeness with a devaluation of anything that's less than that. And again, as somebody who's a relational analyst, it seems to me to be overlooking or diminishing something that's such an essential part of a transformative process for people. So journey through difficult periods. If the dragon appears and you try to run away from it, you can have a wonderful educational experience in panic and paranoia. If you look the dragon in the eye, you go towards it, you see the great anaconda and dive in its mouth, you look at its eyes. So she went through a period where she was convinced she was going mad, horrible confusion, and she thought, well, if I'm going crazy, at least I'm here at Bellevue. And she just let go and accepted that she was going crazy, and what followed was one of total acceptance and love and peace and well-being. And so you hear this theme coming up again and again and again, that the more intense, terrifying, disorganized experiences can be sustained and held in the room, the greater the transformation to occur. Another theme that emerged was a confrontation of warded off emotions. You can laugh, you can scream, you can cry, you can be silent. Many people are grieving deaths that occurred decades ago. It brings up material that they were defended against and repressed, whatever you want to call it. A really cathartic experience liberates or releases energy that's been used to defend against. So this theme comes up again and again, and that's the cost of psychological defensiveness. Psychedelic therapy allows this affect to be re-experienced, to re-emerge, to be faced, to be confronted, to be experienced, and then the cost of the defensiveness has gone away. Again, this is an extremely Western psychological model for how the mind works. And it's not surprising that Western trained therapists would bring this into their concepts of how psychedelic therapy works. Then there's the theme of death and rebirth. An ideal treatment includes a complete encounter, a transcendental ego and rebirth, and spending time on the threshold between that knowledge and everyday interpersonal world. There's going through pain, the dark night of the soul, bad trips, what we used to call bad trips, individuals who can weather the storm and come out of it at the other end have an almost renewed sense of appreciation for the world around them. So again, more about death and rebirth, psychological death. And then transcendence. Layers of self peeling away. There's a rising anxiety as to what will happen, a tough stretch. They may not be able to speak. And with the rapport building, when it happens, there's real comfort in he or she is with me in this. If you, the participant, get the great unity of consciousness, you and the patient are the same thing, and so is everyone else on the planet and every atom of existence. You encounter a higher self, something beyond this realm of not being so cut off and alone in spiritual, existential despair and isolation, able to reconnect. So again, this theme of transcendence, everyone being connected, everything being connected, nature is alive, connectedness to nature, is a theme that therapists saw in the people that they work with over and over again. And you're the same person, but you've changed. So, wrapping up, therapist themes, therapist preparation, following intuition, the importance of rapport, therapist motivations and state of mind, the participant's arc of transformation, and transcendence. So, we have questions for you. We are interviewing psychedelic therapists. What would you want to ask? What did you come here wanting to learn? What do you think we should study? What are the important areas for us to explore in learning more about psychedelic therapy? And that's it. Thank you. Thank you.
Those questions back up for discussion.
Okay. Yeah.
So I have a question. With regard to the breath work that you had alluded to, that you had mentioned, is there any specific type of breath work that is done? And I'm alluding to sometimes some types of yogic breath work for relaxation, pranayama based. Is there any protocol or you say breath work to help relax?
Mm-hmm. Well, the kind of breath work that I put into the training manual was, came from Andrew Weil, and it is basically a prone abdominal breathing exercise where you have your hand on your stomach and feel it go up and down and observe the breath and try to make the inhale and exhale last the same amount of time. Yeah.
I know rescue medications have never been used in any study, but what would be the conditions you would use for rescue medications?
If somebody had intractable panic anxiety that seemed to be traumatic and it was lasting for an extended period of time and there was aggression involved. I mean, I had a very, I'll come back to you one second. I had a very, very heavy woman who received what I think was too large of a dose of psilocybin for our purposes, for what we were intending, because she was so heavy. But I don't think that her circulatory weight was double what a woman who weighed half of her weight would be, and she became quietly agitated for hours. And it was quite difficult for me to bear, because if somebody had been that agitated, in a quiet way, I probably would have considered treating them, because if they came to the emergency room and they were psychotic and brought in, by the police, I would have thought that they were psychotic in a way that would definitely require treatment, just given the phenomenon that was right there in front of me. But knowing that she had received psilocybin and knowing her before, I really trusted that she would come out of it. But it took her almost twice as long as all the other people in the study because she received so much. And it was quite uncomfortable for me. I had a lot of anxiety and certain kind of guilt about it, and a sense of compassion for how much suffering she seemed to be in. But she wasn't. That's what was amazing. You know, when she came out of it, she was not suffering in a panic or difficult way. She was unable to speak, and she was unable to let me know she was all right, because there were so many signals that she was doing badly, and when I would call her name, I could not get her to, you know, like connect with me verbally. Well, mildly. I mean, she was restless and fidgety and always moving. She wasn't like up and running around and physically agitated. And you know, she'd lost her hair to cancer, and so she had a wig on, and it became quite, you know, disheveled, and her clothes were disheveled, and so the whole picture was one in which there was a lot, just like I was uncomfortable. Like this woman is really far out there.
So problematic because you're making it about you.
I know.
Instead of the patient. It's not about you. That's
Well,
so problematic.
I don't think it's problematic.
Not about you.
It is about me.
That person's experience, and
I'm-
you're making it about you because you're uncomfortable with that person's reality. It's not about you.
It is about me. That's one of the things that I've been trying to talk about today, is that when you are an attuned therapist, you have a subjectivity. You are not...
You haven't experienced a psychedelic experience. So
You don't know that.
And you claimed that in the beginning.
I did not claim that at the beginning.
You did.
You weren't listening carefully.
No, I was. I'm a very...
Can you tell us what the outcome was for her? Because I know you perceived, based on what you were seeing, that was your perception, and thank you for sharing that with us.
You,
We learned a lot by you seeing what you interpreted was not actually the case. So thank
Right.
you for sharing that. That means
right.
a lot for us.
I contained a lot of my discomfort with her. And I don't think that it's wrong that I felt discomfort. I did. You know, I'm a human being, and that's what I felt when I was doing this with this woman. But I trusted the medicine, and I trusted her, and I did not use a rescue medication with her, because I thought, I don't think that that is the proper intervention for her at this time.
So what occurred for her in the end? Did she have some kind of transformation?
She had a beautiful experience.
Okay, can you share that with us?
Sure. And if we could watch the film, she's one of the, well, I actually probably shouldn't reveal that. But anyway, she's given us permission to show her everywhere. She felt a resurgence of aliveness in her life, and a resurgence of forgiveness, not a resurgence, but an emergence of forgiveness for her daughter. She had somatic changes. She'd had a number of different kinds of like back pains and hip pains, all of which resolved as a result of this. And she went back to her volunteer job. And she had a beautiful experience of transcendent connection to God. And she said, I couldn't speak. I could not connect with you. She said, I could tell you were out there, and I could tell you wanted to reach me, but I couldn't reach you.
Were you trying to provide reassurance?
Pardon?
Were you trying to provide reassurance to her? when you
Well,
thought-
yes, I was trying to connect with her through her name, and I was trying to make eye contact with her, and I was unable to do that for a couple of hours.
Yes, the session's scheduled for 12:30, so maybe there's time for the film.
Okay? That's a good point. Yeah.
The question, what do you think we should study? I'd be interested in how therapists see the spiritual bypass phenomenon.
Hmm. Can you say more about that?
It's an avoidance measure to avoid the historical psychological material by going to spiritual levels.
Right.
So it's considered a defense mechanism, basically.
Well, that's something that you see sometimes in dedicated yoga practitioners and meditation practitioners, and it's really, I think it's a kind of dissociation from affect, from...
I'd be interested in how the therapists think about it and see it and work with it.
Can I just add something to that?
Sure.
Based on the preliminary interim analysis that we've done, we have seen this theme that some therapists have even recognized out loud in their interviews that, you know, there may be this tendency to focus exclusively or to over-focus on that spiritual experience. So we haven't used that word in our questions specifically, but I think it's something that we may actually see people talking about in the emergent theme. So I hope to actually tap into the literature on that when we do the final analysis and see if we can address that phenomenon, whether or not that's a problem or something that there needs to be more conversation around. Because I do agree that there should be more conversation around that.
Yeah, and it relates to your comment about the emphasis on a complete mystical experience as opposed to a psycholytic therapeutic process.
Right, precisely.
Well, I think that there's a little bit of an overinvestment in the complete mystical experience, and the idea that if you have one dose, it can last for 8 months, as if showing that's how powerful it is, which I think is kind of a masculine idea of, you know, look how far I can throw this, you know, ball, and how powerful this ball is. And it's really my fantasy that there are many different ways that psychedelic medicines can be useful, and some people should take them once a month, and other people every 2 weeks, and other people every 3 months in small doses. And the idea that, you know, one dose does this mystical experience and then you're changed for good, I think sets a kind of unrealistic bar, and it emphasizes the wrong thing.
I think we need more experienced therapists in the research team. So thank you.
Thanks. Yeah.
Agreed.
I have a question, but first she said her hand.
Oh, you're right. I'm sorry. I forgot to come back to you. No, my mistake.
If personality disorders or sleep or have been part of like exclusion criteria all along, and if not, what your experience has been in terms of like your experience of therapy and work,
Yeah.
whether it's problems or just meaning. I know you hear a lot about because of your framework. You hear a lot about relationships. So, for example, what particular things might have arisen in patients' work together.
I think it's a great question. Personality structure and personality diagnoses were not a diagnostic criteria for admission or exclusion from the study. And I can tell you that we did have one person who, in the first session, after getting through all of the, you know, preparatory, you know, like the consenting and the SCID, you know, work, and she was consented, as they say, which means made it through the entire preparatory process in order to start the therapy, to start the preparatory sessions. She had, in my opinion, a paranoid personality structure. And all of her studies were about, you know, persecutory doctors and nurses and family members, and how disappointing and hurtful everybody in, you know, in her world had been toward her. And I did not think that psilocybin therapy was a proper path for her. I thought it might provoke an intense paranoid regression for her and be more traumatizing than helpful to her. I may have been wrong about that, but that's like a personality diagnosis that I thought, you know, we needed to eliminate her for. Then there were also, I think, that more anxious, obsessional people who have tight need for control have a harder time letting go into novel experience, into loss of control experience. And I think that they did not get as much into a spiritual realm.
In
And
those cases, would you advocate for a higher dose?
I would advocate for more frequent doses and raising them as the person learned how to work with the medicine. I mean, I think that you don't necessarily learn how to work with the medicine in one dose. right? Right? People who are obsessional and fearful need to learn how to trust the experience and trust the therapist, just like in any kind of therapy. Some people can start like really getting into it right off the bat, and others it takes them a year to learn to trust you and see it letting themselves reveal themselves to you. So I think that there's a lot to be learned about personality structure and psychedelic therapy.
That would be my answer.
Thanks. Did you want to
Can I
comment?
add to that too? Because I just want people to keep in mind, right now, the therapy work that we're talking about is all stuff that's gone on in the research setting, so in the clinical trials setting. So, although our goal is to provide the best treatment possible and take care of our participants in the best way that we can, it's also to do the trial in such a way that, that we are very strict with the inclusion criteria, that we do have a very specific treatment group, that we're showing the biggest differences that we can between the active group and the placebo group and all of that. So that doesn't necessarily mean that people that were not including in the studies couldn't be helped or could be helped by a slight variation on what we're doing. And I think that a lot of us would like to maybe to try a higher dose with this personality type or try something a little bit different. That will come. That's where we may be able to do those things when we get to an expanded access situation or something like that. But for the clinical trials, we are making those kinds of cutoffs and decisions with a second set of goals in mind. So, and that can be hard for us too, the clinicians and us as well. But there is that balance that needs to be made right now.
So I think your question also brings home why it's so important for there to be trained psychologists, and psychiatrists, and psychotherapists, and working in psychedelic therapy, and not just diagnosis-oriented clinicians, because if you're doing a study with treatment-resistant depression, there may be a broad spectrum of personality types. And there certainly is a depressive personality type. If you're doing OCD research, there is an OCD personality and an obsessive personality type. And how the personality aspects overlap with the DSM-5 diagnostic categories is a really complicated question. And I think that's one of the risks of diagnosis-oriented research without having a personality spectrum that's a component of it. Yeah.
To the first question, I'm kind of curious in terms, this is probably different because of the research setting that this work is done in, but about supervision of the therapists in like a clinical sense and the encouragement of therapists to be in therapy themselves when working with patients. So, like, what kind of modality would you imagine for therapists to be in therapy themselves when their work is primarily with psychedelics?
Well, I think I mean, the ideal that I have in my mind is a model like psychoanalysis, where the therapist undergoes psychedelic therapy himself or herself over a period of a couple of years, with maybe a few sessions a year or even monthly, with in a private, confidential setting, just like a psychoanalyst does, at the same time as doing treatment of people in psychedelic therapy. Because what gets when you're involved in a treatment yourself, you develop a very personal relationship with the therapist and your very own relationship to the treatment modality, and that affects who you are as a therapist. So I think that a really well-trained psychedelic therapist has to have experience with psychedelics, and over a period of time, not just once, but in an ongoing way, to learn, who he or she is, in that psychological milieu, and the relationship that they have as a patient to a therapist, to understand themselves as a therapist to a patient. In our study, though, we didn't have much supervision. The therapist did what they thought was best, and we discussed it in a team setting, but that's not supervision. That's a case conference where people always put their best foot forward. And I mean, supervision is where you can really reveal your vulnerabilities in a private, confidential setting, and that's really quite different. Yeah.
So I would agree with your last statement in terms of having a group of therapists who
are trained in procedures and have experienced psychedelic therapy themselves. Perhaps a broader question would be any ideas on how that might be achievable given the legality of psychedelic substances.
Well, I think that MAPS has done an awesome, magnificent job of integrating therapist experience with MDMA as a possibility into their PTSD MDMA research project. So I think that's a wonderful model for doing it. We did not get that together at NYU. Yet. Really, it was all we could do to keep our study going, focusing on the participants receiving the medicine. And there are a lot of flaws in the overall structure, and certainly in the structure of the training of the therapist. But it wasn't about therapist training. It was about treating the patients. And the therapy kind of like, sort of came together as needed around it to help it happen. But the focus was on getting the medicine into these patients and supporting them in their journey. And so it left a lot to be desired. I really can admit that. Yeah.
We were talking earlier about some of the factors that have been played within the research. Has there been any consideration for not using any music or at all, and also occur in a natural setting?
There is never any serious consideration of not having music. The idea might occur, but it's a deeply, deeply ingrained tradition, going back to Stan Groff. And I think that it would be a hard fight to make the music go away. It would. And, when I would challenge the idea that it was a good idea, because if you look at shamanic ceremonies, there is a lot of music. There's a lot of singing, a lot of rattling, a lot of sound, natural sounds. And so I think silence would be a peculiar condition for a psychedelic journey. I think natural sounds and man-made sounds made in the present, would be much better than a pre-recorded soundtrack. And in shamanic ceremonies, the shaman or the shamanic assistants will sing, make music, play musical instruments that respond to what's happening in the room or in the maloka. And that's, I think, much more creative and alive. And there are natural sounds, that accompany. As far as being out of doors, I don't think that academic psychedelic research is going to be outdoors anytime soon. Because it has to occur in a place near a crash cart, and even though the idea of needing a crash cart is kind of preposterous, it's seen as contributing to safety. Excuse me. I have a colleague, Tanya Sippy, who has this very same idea and really, really wants psychedelic research to happen out of doors. But I don't think it will. There's so many things that research demands that are not in the best interest of the process. They're in the best interest of the research. And they're what make the research safe and doable. Yes? Hi.
I was curious if you'd be interested in collaborating with other institutions to look at blood biomarkers.
Sure. Sure. Why not?
What kind of workers?
Blood biomarkers? Yes, ma'am?
I have this vision where in the future there could be a hospice where patients have this healing modality as a treatment option, and I just want to get your thoughts on maybe like how to make that possible. Obviously, years and years in the future, because considering all the legality issues and all that stuff, but I think it could be an adjunct to like a center for entheogenic exploration. That's a whole other idea on its own, but what do you think about like a seed hospice?
I think it'd be wonderful to have a setting within hospice in which psychedelic therapy could be given, especially if there were access to nature and access to non-psychedelic trance-inducing modalities as well. I also think that it would be great for family and caregivers to have access to psychedelic healing because they often really need it, could use it. So I'm wondering, about George's idea of watching the movie. Would everybody like to see this film and stay until? Okay, yeah.
I'm curious, have you had any clients that really were adverse to listening to the music and just wanted to have the silence? And were they ever offered to be able to use the rattle or drum themselves, and have the therapist ever use the rattle or drum in the research study?
Great question. You asked a number of questions. If somebody really didn't want to hear the music, I would turn it down. So they didn't have to listen to it. And she sang. This particular person sang. We did not have a rattle in the room, so that was not something that we had access to. And I think that it was really meaningful for her. Because I think she felt invaded by the music after she decided she didn't like it. And the instructions were to like fall into your loathing of the music. But I'm not sure that I would agree that that's always the best thing to do. Especially pre-recorded soundtrack. Okay. All right. Does anybody know how to get the bar?
My name is Estelyn
Off the
Walkoff,
bottom?
and I work as a
View full screen.
I did that.
Just give it time
Okay.
and move the mouse away from it.
therapist.
My name is Gail Cowan. I'm a adult literacy teacher, part-time at the public library.
So my name is Eddie Meritz, and I work as a documentary cinematographer, largely documentary cinematographer. I do some other kinds of photography as well.
My name is Tammy Burgess. I am Assistant Director at Brooklyn Workforce Innovations. We provide training programs for unemployed and underemployed adults with barriers to employment.
Well, I was diagnosed 5 years ago with a type of lymphoma that was untreatable. And not only was it untreatable, but everybody who had it had died from it. It was aggressive.
In 2003, was 10 years ago, was my first bout. I've had 4 bouts with breast cancer in my left breast. Beat it back each time, including this last one that started last fall in 2012.
I was diagnosed with 2 cancers, actually, ovarian cancer, and also we later found out lung cancer in January of 2013.
I had a symptom, so I went to see my doctor, who sent me to a urologist, and the urologist said, yeah, you have bladder cancer. And he said, this is the language he used, he said, it was a bit of a rare bird. It's actually small cell carcinoma, which is almost always found in lung cancer. And it's found in less than 1% of bladder cancers.
It was just shocking. It was just like somebody pulled the floor out from under me. It was like I was numb. I mean, I would just lay on the couch. I didn't go to work. I'd field some phone calls, I just lay on the couch. I was watching endless episodes of The West Wing, and I think I was kind of like almost comatose.
Always in my life, I've been an anxious person. And naturally, when I was given that diagnosis, my anxiety shot up. And even though years and years and years keep going by and I'm still okay, I know very well that this could return at any moment.
You know, I was dealing with the clearest message of mortality that I'd ever received. You know, because nobody said, oh, we've got this under control. Just every dark thought, you know, ran roughshod.
When you're anxious about cancer, everything else becomes anxious. Like any little issue just becomes kind of blown up. I kept kind of going back to these moments, like the moment when I had my CT scan, the moment when I was told that I would, you know, I had cancer, and kind of looking at all the paperwork and reading the CT scans, and I just couldn't get those things out of my head, and I couldn't seem to move forward. I was really scared. I was scared about it coming back. I was scared about what dying would be like.
The cancer diagnosis, of course, is one of the ultimate unasked for things that you can have in your life. And why is it unasked for? It's unasked for because it changes how you see yourself, how you are in the world. You suddenly have to pay attention to something you hoped and dreamed you would never have to pay attention to.
When getting the diagnosis of terminal cancer that there's no cure for, that fear led me to do everything I could so that I could open my heart. And that means prayer and meditation, and I went to every religious type of gathering I could. I wanted everything there was out there.
You know, one thing that I became very aware of when I got this diagnosis is I love my life. I love living. You know, I'm very attached to living. I like living. You know, I don't know about dying. You know, so. You know, there's just a sweetness that's with life, that comes with life.
After the surgery, all my friends, I remember waking up and my friends and my brother are all standing there looking down at me, and they're just beaming because they had been told it went so well. And I kind of got it, but I still had no relief. Like anytime they gave me good news, I would kind of ride on the high of my friends, but I had no kind of high on my own from it. Like I had no sense of relief of it, that things were going well, even though they were.
I had surgery, then I got it back again. I really went to work on myself because I thought that if I were going to die much sooner than I had planned, then I wanted to understand myself better. I wanted to understand spirituality better. I wanted not to have a bitter heart, and I wanted to be open. So I did what I could for the past 5 years, and now this study came along.
NYU Cancer Health Clinic on 34th Street, the social worker there showed me a flyer about the program, and I was very interested, so I called the number and I started being called and interviewed on the phone.
I had great hopes because not only was there psychotherapy, but that there was also this plant. And I have a lot of respect for psychedelics, and so I had great hopes.
Maybe with what's going on in my life, this is a good time to take a look. So I was very open to it and eager, and I was so happy to hear that this was going on, that they're really studying this.
I felt like I could learn something about myself. And particularly, I think I was open to learning something that could help me face death.
I'd never been in any sort of therapy before, and I really kind of learned a lot doing it, and there were some things that they kind of pointed out to me that were just really, really helpful.
It's like he created a timeline, and nobody ever had done this for me or with me. And he said, okay, so here's your birth, and here's your death, and here's cancer, you know. So can you tell me about some other significant events in your life?
So I started telling myself my cancer story, because that was the first thing that I had done when I met Tony and Bonnie, was to kind of tell your cancer story. So that was kind of interesting for me, because I'd never really walked myself through or told myself my narrative or really thought about it as a narrative.
And I think that was like hugely important for my sense of trust, but also in this study. I mean, one, I was going to be taking an hallucinogen, and it's just better to be with somebody who at least has an idea of who I am.
I mean, if you're going to do something like this, there's going to be people with you. You're going to be in a safe environment. They're not going to let anything happen to you. If you start having a really awful time emotionally or something, they're going to help you. They're going to do what's necessary.
I think taking it with intent and talking about that intent is just really critical to the kind of successful outcome. I think if I had just done it the first day, it wouldn't have been the same. If I hadn't done the therapy and kind of the homework to make the experience valuable.
They've done a really good job in making, I guess, what was once an exam room into a pretty comfortable living room kind of room. There's a couch, flowers, and books, and it seems not study-like. You go in 2 sessions. One is a placebo, and one is the real plant. You don't know which is which. The people that were with me, my guides, my mentors, are the 2 psychiatrists that I had worked with previously in many sessions, so I felt like we knew each other, which was wonderful. I can't imagine doing it without them.
So we did a little ritual, came in a white capsule. So we stated our intentions, and my memory of that is I said I just want to stay open to whatever happens.
And this time I read something that I wrote myself, because at that point I was kind of in this writing class. So I read that, and then you take the pill, and then you lay down on the couch again with the music.
You're advised to wear eye shades and lie down on a couch because the object is to go inward.
It took a really long time for it to take effect.
I remember saying, God, it just seems so long. And Jeff came over, and he knelt by me, and he said, it's taking exactly as long as it's supposed to take.
Music was really important. It was both an anchor, but something that propelled me. I felt it the whole time. It was very important.
The sound really directed the experience, and it directed the experience through my body.
And what happened first, and actually lasted much of the day, was that I experienced great anxiety. I began to see that it was actually a level of my mind. And underneath that, I also began experiencing great emotional pain. And it seemed to me that that pain was the pain of suffering people on the earth, and also the pain of the earth itself. I was actually feeling that I was holding the pain of the world in some way, and in particular, because I had been listening to Black spiritual, I felt, I could hear the pain in that woman's voice who was singing the song, and it brought to me the whole gestalt of slavery and what that is to pull people out of their homes and treat them like animals. And I sobbed and sobbed and sobbed because of that.
It was so beautiful and so sad and so happy, so joyful, that it was just the range of those emotions, and it just kept going up.
The more I kind of surrendered myself, the deeper it became. And I know I was crying most of the time, and I felt like my tears were kind of like this offering, of surrender to this experience.
The things I was experiencing were taking me in, which I think I kind of hoped for, but I didn't realize that I wouldn't be able to talk about it for quite a while. And it was hard to answer questions like, what are you experiencing now? Words failed me, which is such an unusual feeling for me.
I mean, it was so inexplicable that the word ineffable came to my mind. Now, that's not a word I use every day. I don't know if I've ever used it in my life.
I also wanted to direct what happened. I wanted to have this wonderful, enlightening experience, and I was trying to sort of push that to happen, and you can't do that. When you do that, you're fighting something.
The ability to just be held by my mentors greatly relieved me. The worst pain and the worst fear and the worst anxiety turned into something that has opened, which is the most precious thing I've ever known. I had this feeling coming over me, and the thought was of compassion for myself. You know, that touches me the most. That's such a gift.
I started having sort of like realizations, and it sort of opened a part of me that hasn't been open in a long, long time.
I did have a very clear experience of my bladder not being in me anymore, that there was part of me that was no longer with me. And it seemed like part of the experience was to let that go. And I remember combining it with gratitude for everything, for being alive, for being fortunate enough to have my human birth, no matter what happens.
I remember thinking about how, we all die, you know what I mean? We all go back to where we came from, and that was very comforting. I felt that the message coming to me is that, life is about, accepting it without knowing there's no knowing. I mean, you don't know how it's going to end. You don't know what your death is going to be, and that's just part of the deal of life.
I was born with the ability to feel compassion for other people, but I have not been a person to feel compassion for myself. I hold myself to a high standard, and I judge myself pretty critically. And to have that moment of grace where I was just, I'm okay. I'm okay. I'm okay. It's all right. I can't put it in words, but I'm so grateful and touched and shocked.
I needed to stop talking and look inside and find that I was part of it. I was part of everything. I was part of God, that you are too. Everything is, and you can call it whatever you want to. I don't usually call it God. I just call it the One.
When you ask me if I'm religious, I'm not like religious per se, but that's the closest corporal understanding that I'll ever have to know that God is in me. Yeah, that's what it's like.
I mean, I know these things. I mean, they're all like cliches and everything, but they weren't then. They were like just totally real, and realize that, the total insanity of war. I mean, it's hard to comprehend how we can keep doing that to each other. I will never forget that. I have that with me, and I will always have that with me, and I'm so grateful for that.
Somebody called me up today and they said, "How are you?" And I said, "Wonderful." And I am 65 years old, and I just heard that coming out of my mouth. I have never said that. Never. And that's how it's been. And so what happened to me that day was that I got to actually see the levels of my mind and see where anxiety is for me, that it's actually just a level and that there are other levels beneath. And as a result of dealing with that anxiety that day, seeing it like that, everything's been different afterwards. since then. I can't say that I don't get anxious, but when I do get anxious, I just let it go because I know it's just a level of mind. So it's all changed for me.
Well, the first thing experience did is it finally did kind of give me that relief. You know, like I really felt like so much better. And it also kind of became demonstrated in, you know, in my behavior. Like I had an easier time handling things at work. I was able to let little things go much easier. I could sleep without medication. You know, I could sit in a quiet room and write, you know, and not get all anxious. So there were some real immediate kind of impacts that affected both kind of my emotional health and also my day-to-day behavior and how I coped with things.
It's just sort of opened me up to everything, like the universe and to people and you know, from the furthest strangers all the way up to my own family and my friends and my acquaintances and my neighbors and some of my neighbors in their relationships. It's just sort of affected everything.
I mean, one of the things that I'm really afraid about is recurrence, right? And I don't know if that'll happen, but I will say that if it happens, I'd be shaken. But I think I also know that I'll have a better idea of what it is to be living.
One of the things I really came out with, and this helps me so much, is that, you know, grief is for the living, the dead are just fine. You know, that even if I have a painful death, I'm not going to take it with me.
I was on the treadmill the other day, and this thought entered my mind, just came through my mind, and it said, I want for nothing. Nothing. Everything's perfect. And that's how it's been. That's how it's been. And I find myself so much more connected to everyone and everything. And what greater blessing is that? Especially for a person who held herself apart.
Psilocybin is something really important, that it needs to be studied and it needs to be found out about. And I hope they go on, and I really wanted to get that on the record, that I think it's so important.
It was both an inner journey, but it was also an outward journey. I just felt really connected to the people in my life and to the universe. And I just felt this great sense of love and that's, you know, kind of, it's corny, but that's kind of what matters and that's what holds us together.
I really felt connected to everything, and the whole universe. I mean, that is God or the creator or whatever you want to call it.
You know, since restarting working as a therapist, I've been feeling that, boy, I know I could help these people more if they could go through something like I went through. And I just know that if in the future this could be used with all patients under the direction of mentors, shamans, psychotherapists, it would make for a much happier world. If people could know how connected they really are, connected to spirit and connected to each other and connected to nature, and if people would know that, so much of their fear would dissipate, so much of their anxiety would dissipate. And I just hope and pray that these studies will continue and open up the field.
I was thinking about that during the talk, and you know, when you're a physician, you're taught first do no harm. And I gave this woman medicine, and with the hope that it would make her well, and had this question, you know, have I harmed her in some way, and or is she getting well? And it was really holding it for 2 or 3 hours and asking the question, you know, as you did, about when to use or whether to use a rescue medication, and having to make the decision, yes or no. You know, it was a challenge. But you can see what she said about it was so poignant and so moving. Any other questions about the about the film. Yeah, Pat Murphy, Casa Vera Films. He volunteered his time and energy and did all of these for free, and did the editing. And he's got a film, Psychedelia, which it might be being screened here. I'm not sure, but it's fine. It's a fine film. Okay, well, I want to thank everybody for their attention and good questions and kind words. Thank you.